Hey guys, today we're going to go over atrioventricular nodal reentry tachycardia, also called AVNRT. Today's objective is to define AVNRT, understand the basic pathophysiology of the pathways, recognize the three forms of AVNRT, and then get into the bread and butter, the symptoms, causes, triggers, and past medical histories related to it, and then go into treatments, interventions, and transport considerations. AVNRT is the most common type of cerebroventricular tachycardia. It's caused by an impulse at or near the AV node. So unlike Wolff-Parkinson-White, AVRT, and other SVTs, this is coming from right there in the AV node, not up from the ventricles. Most of the time it's caused by a PAC reaching the AV node while the fibers are still in refractory. This allows abnormal electrical current circuit to perpetuate from the AV node, causing those high heart rates of 150 to 250. Good diagram here for us. Easiest way to think of it is slow and fast. Your slow is like your distance runner. It takes some time to get from point A to point B, but then he can do it all over again pretty quickly. Your fast pathway is your sprinter. It's going to go from atria to ventricle super quick, but he's going to have to rest before he can do it again. So your normal pathway, impulse comes in and splits. Your slow pathway goes down, takes some time, fast pathway beats it there, depolarizes the ventricles, and then the slow pathway hits resistance, can't go up this one because it's in refractory. For AVNRT, your normal pathway is going on, and you get this PAC that comes in. PAC comes down, guess what? Fast pathway is still in refractory, so it's unexcitable tissue. Guess who's excitable? Slow pathway. So it's going to go down here, make its way all down, again, depolarize the ventricles via the bundle of His and Purkinje. But now when it's down here, the fast pathway is excitable again. It's out of its refractory period. So it's going to retrograde up back to the atria. By the time it gets to the atria, hey, guess what? The slow pathway again, with the quick refractory periods, ready to be excited again, and it's going back down. So now you've started this perpetual loop over and over again of constantly depolarizing the ventricles, getting these high heart rates. 12 lead EKG, kind of looks like your standard SVT. Narrow QRS, tachycardia 150 to 250. Won't see any P waves. They're going to be caught up in the QRS. But something you may look for is these pseudo S waves, retrograde atrial depolarization. You'll see them here in lead 2. It's kind of a common thing for AVNRT. Take a look for it when you do that. Also, it's a pseudo R wave that you can see back here in V1. Kind of a bump right coming off the QRS. And then the pseudo S is the depol right there. 90% of cases is AVNRT is the slow to fast pathway form. Occurs when the atrial impulse reaches the AV node while the fast pathway is in refractory. That's what I just showed you on that diagram. Allows that perpetual loop. Less common is fast to slow. This is about 9% of cases. Again, the fast pathway is going retrograde up the slow pathway and exciting it from there. And then slow to slow is about 1% of cases where the slow pathway is refractoring itself, causing the AVNRT. Symptoms, very similar to SVT, besides they start and stop pretty abruptly. Palpitations, chest discomfort, dyspnea, anxiety. Rare cases, you'll get syncope. No apparent causes of AVNRT. History is of PACs and PVCs precipitate. So thus, caffeine, tobacco, alcohol, stress will cause increased risk of PACs, PVCs, increasing the risk for AVNRT. Females, 3 to 1 more likely to get AVNRT than males. No real age group that stop or start at, but they're saying the first 20 years of life is more common. Assessment, general PCGs, cardiac monitoring, get a history, get your 12 lead. We'll start with unstable since it's the most serious. It's uncommon for AVNRT to cause hemodynamic instability, but still you're going to apply your stat pads, sedation, analgesia if you can before cardioverting. Cardioverting's not working, give med control a call. Stable, a little more common, perform vagal maneuvers. Everybody's done them before. Bear down like you're having a bowel movement, cold ice water on the back, blowing out candles through a syringe, something to just cause that Valsalva maneuver to try and reset the AV node. Go from there, your standard 6 milligrams of adenosine, rapid IV push, 12 to 12. If not effective, we're going to go to the DILT Try the bolus at 0.25 mg per kg. Doesn't work, try to go with 0.35. If you get some rate capture, but it comes back, then you start looking at the DILT drip. Again, if the DILT drip's not starting to show some signs of getting to that target heart rate of 100 beats per minute, give med control a call. These are the PCGs to reference, what page they're on. We've all seen them, we all do them. All right, guys, that's pretty much the bread and butter of it. I got a quick quiz for you, 5 questions, get an 80 on it, make everybody happy, and then we'll head over to the sim lab and knock these things out. Appreciate it.